CARTITUDE-4 uses cilta-cel, which is a dual-binding BCMA-directed CAR-T cell product. And that was used in the CARTITUDE-1 study, in which heavily pretreated patients with a median of 6 lines of prior therapy were included. And at the ESCO and EHA, the median progression-free survival for this patient cohort was reported to be amazingly 34.9 months. Now, the idea is if we use CAR-T cell therapy earlier in the treatment of multiple myeloma, it might be even more effective and maybe less toxic. And in CARTITUDE-4, actually patients were included that were lenalidomide-refractory, because more and more patients are going out of the first-line therapy being lenalidomide-refractory. And in addition, they had to have received 1 to 3 prior lines of therapy. Then patients were randomized between standard of care, which at that time when the study was designed for lenalidomide-refractory patient was PVD or Dara-PD. And in the experimental arm, patients also received PVD and Dara-PD until cilta-cel infusion. And then patients were analyzed for safety and efficacy. 208 patients were randomized to cilta-cel and 208 received standard of care. The patients were fairly well matched between the two arms. So we had about 6% patients ISA stage 3, about 20% of patients in both arms with a soft tissue plasmacytoma, and 1/3 of patients had received 1 prior line of therapy, 2/3, 2 or 3 prior lines of therapy. In both arms, about 60% were high-risk patients, including patients with gain or amplification 1q. And if we go for patients with 2 or more high-risk cytogenetic features, about 21% in both arms had 2 or more high-risk cytogenetic features. Triple-class refractory patients, about 15% in both arms, and about 22% of patients were Daratumumab refractory. The primary endpoint was clearly met. Progression-free survival in the standard of care arm, as expected in this patient cohort, about 11.8 months. Median progression-free survival not reached in the cilta-cel arm. And the hazard ratio for progression-free survival was amazingly 0.26%, the best ever reported in patients with relapsed refractory multiple myeloma. And actually looking at all key subgroups, like patients with 1 or 2 or 3 lines of therapy, ISA staging, presence of soft tissue, plasmacytomas, tumor burden, cytogenetic high risk, refractoriness, or prior exposure, all subgroups benefited by an improved progression-free survival in favor of the cilta-cel arm. Now, if we look at PFS by prior line of therapy, cilta-cel improved progression-free survival versus standard of care, where the patients had 1 or 2 to 3 prior lines of therapy, and actually comparing patients with 1 prior line of therapy and 2 and 3 prior lines of therapy, at least there is a trend to improved progression-free survival of patients that only received 1 prior line of therapy, but longer follow-up is clearly needed. If we look at secondary endpoints, response rate 84.6 versus 67.3% in favor of cilta-cel. For the ITT patient population, CR rate 73.1 versus 21.8% in favor of cilta-cel in the ITT population. MRD negativity in patients that were actually evaluable, 87.5% in the cilta-cel versus 32.7% in the standard of care arm. And when actually patients were analyzed that received cilta-cel, these were 172 patients The overall response rate was 99.4% and the complete remission rate 86.4%. And this patient cohort, the 1-year progression-free survival rate was 90%. So really impressive results. What about toxicity? Hematological toxicity evenly distributed between both arms. Cytopenias in the cilta-cel arm resolved to grade 2 by day 30, grade 3 and 4 infections, similar between the two arms. Also a similar rate of second primary malignancies. There were more deaths in the cilta-cel arm due to the fact that more patients had developed a severe COVID-19 infection and died due to COVID-19. And so strict prevention measures and aggressive treatment of COVID-19 was introduced, and with this, no further death due to COVID-19 was observed in the cilta-cel arm. What about typical CAR-T cell toxicities? About 76% CRS, any grade, 1.1%, grade 3 and 4. Neurotoxicity, 20.5%, any grade, 2.8%, grade 3 and 4. 30 patients had a non-ICANS neurotoxicity, of which 16 had a cranial nerve palsy, mainly involving a Bell's palsy, and all 14 of them completely recovered. 2 are already recovering, 5 peripheral neuropathies, and 1 case of a movement and neurocognitive treatment emergent adverse events, so a kind of Parkinsonian-like syndrome. But when compared to the CARTITUDE-1, when patients after 6 lines of therapy were included versus CARTITUDE-4 with 1.3 prior lines of therapy, there was clearly a lower incidence and severity of CRS, ICANS, and MINS and some cytopenias, indicating that cilta-cel is better tolerated when used earlier in treatment, and that effective bridging therapy enables better control of tumor burden prior to CAR-T cell infusion. So in conclusion, cilta-cel significantly prolonged progression-free survival versus standard of care in patients with lenalidomide-refractory multiple myeloma and 1 to 3 prior lines of therapy. The progression-free survival benefit was seen across all subgroups, and all the CAR-T cell specific adverse events were manageable. And when compared to the CARTITUDE-1, so with more heavily pretreated patients, CARTITUDE-4 indicates an improved tolerability of cilta-cel when used earlier in treatment. And with this, the conclusion can be that cilta-cel has clearly the potential to become a new standard of care for patients with lenalidomide-refractory myeloma after first relapse.